Welcome to Cutting Edge Pain Relief, and today we're talking about how to be able to treat sciatica, specifically pain that goes down the leg, by using different treatment options injected directly into the spinal disc in order to be able to get pain relief. If we haven't met, I'm Dr. Orlando Landrum, a regenerative medicine and interventional pain physician that helps teach patients and those people who care about them how to be able to find options for pain relief and improved function. Today, we're doing a live stream, meaning those of you who are joining us live, please jump in, ask questions, put in your comments, and we'll be happy to be able to address them live. That's talking about intradiscal orthobiologics. So, as you guys know, we really are not trying to be fancy. We want to make sure that you understand what it is that we're saying. So, what that means in regular English is if we're looking at the context of the lumbar spine, right? And we're taking a look and we can see the bone, the disc, the nerve, the area that we're trying to target is the disc. And what we're talking about doing is being able to add an injection directly into that disc that's using different parts of your own body, specifically certain types of cells. And in this context, we're going to talk about different types of cells. We're going to talk about PRP, which mainly comes from the context of blood. And then we're going to talk about potentially autologous stem cells. And initially, I'm going to talk a little bit and kind of walk you through the basic understanding. And then we're going to refer to some research so you can be able to see that this is not just basing it off of a visceral or gut reaction, but more that there are studies that have been conducted and can be able to show you what are likely outcomes and results. Those of you who are joining, thank you so much. Specifically, thank you, Elaine, for joining to us as you do traditionally every week. And if you have questions, again, jump in and ask. So first and foremost, let's talk about who might be a candidate for this. So there are different types of disc bulges, as we've covered in a number of different talks, where we've spoken about midline bulges, we talked about paramedian bulges, we've talked about sequestered fragments and those type of things, and different ways to be able to treat it that aren't reliant on just traditional open surgery, which historically has needed to be the case, where you had to open up the entire back, make a huge incision, and then go after that disc. Then there's been the evolution from microdiscectomies to, if the surgeon or institution is a little bit more advanced, sometimes the utilization of a transforaminal endoscopic discectomy or something of the sort. Other individuals will use metric tubes and microdiscectomy. All fancy words, which in essence mean let's open up the back and let's go get this disc in some type of way, right? But let me give you a different postulate. Let's say that you have that disc bulge that's there, right? And that disc bulge is basically coming from the disc, right? And that disc is then, if you're using my pen, coming back and it's pressing against the context of that nerve root in some formation, right? What we want to do is to say, can we stop that bulge? Now, there's a number of novel different types of treatments to try to do that mechanically that are some of the things that we describe. There are ways to be able to enter that percutaneously, meaning using a needle to get into that area, but it hasn't been as developed in some fashions, shall we say. But what we're talking about is using an autologous orthobiologic treatment, meaning we're using cells to try to accomplish the same type of mission to be able to decrease the size of that disc. So for those of you who have problems like this and have had issues like this, some of you would say, well, I did some research and I actually found that disc bulges sometimes can go back on their own and they can resolve. And occasionally that can happen. And so if we're going to talk to you about those type of disc bulges, let's give you one of the studies that's looked at that. So there are studies that have looked at a number of different disc bulges, and they said, okay, depending on the size, its location, what's going on with it, is the interval for it to return back to the way it has been as short as 3 months, which isn't that common, to as long as 9 to 6 to 12 months, right? And thereafter, after it resolves, the symptoms seem to improve pretty quickly. The challenge is for many people is waiting 9 to 12 months on average for pain that can be pretty debilitating is sometimes really difficult to wait that amount of time. There are ways to try to see if you can be able to improve that, things like doing physical therapy or traction or other things along those lines, which are conservative measures. And historically, those of us who've kind of existed in that space have tried to be able to have patients do some of those things. But when the pain is debilitating, is causing weakness, or is just unremitting, you have to be able to intervene and use other treatment options. So that's what we're going to talk about today. So there's two different variants that, for the most part, you can be able to utilize. Prior to doing intradiscal therapies, most docs that exist in this space will consider, can we do treatments that are able to affect the disc without us going inside the disc? And many people would say, why are we just not going direct for the treatment of choice? Why are we not going for the gusto and saying, let's just get into the disc and be out? That's what we're doing normally for surgical. But what we see in the surgical literature is that there is an occasional context of infection. Is it incredibly prevalent? No, but it does have some pretty serious consequences when it occurs. And so what is that I'm referencing is when you get into the disc, you also have to be concerned about the context of infection. And most people say, well, anytime you puncture the skin with a needle or you make an incision, you have the risk for infection. And that's true. And historically, we tried different things like lavage technique, which basically means putting water in there to try to clean it out, or using antibiotics of different formulations, whether that's oral, IV, either before, during, or after the procedure/surgery. But the challenge that occurs with the disc is it doesn't have good blood flow. There's blood flow into bone, there's blood flow in other different parts of the body and such, but blood flow into the disc is fairly limited. And the reason why that's important is so those different other measures that you would use to be able to convey a way to protect the disc from infection really isn't that efficacious, meaning it doesn't work as well, right? So what we want to do is to try to be as exacting to try other techniques before going into the disc. When we look to go into the disc, there has been a number of different surgicals as well as percutaneous ways to try and treat with either antibiotics at the skin, vancomycin, and other things along those lines. But we haven't really seen how to be able to mitigate that risk well, even though it's small and low. So we try a number of different techniques prior to going into the disc, but at some point in time, it may just come down to it that, you know what, we just got to go get it. So we're going to go into the disc and we're going to make a choice. Should we go after something that's called PRP, or should we consider using stem cell? And we're going to look at two different treatment options that really kind of address that. The first is looking at the utilization of PRP. And it's a study that had a pretty robust number of researchers that were involved with it. And so this is the title. Lumbar intradiscal platelet-rich plasma injections, a prospective double-blind randomized controlled study, which is always interesting to me. And the reason why I say that is because as a doc who exists in the pain and regenerative medicine space, frequently I have patients that will have told me that they talked to another doc and they have said, well, there's no studies that have looked at it, specifically no high quality studies that have done a randomized controlled trial. You could actually go to PubMed and you don't need to be a physician or a nurse or any kind of healthcare provider. And for free, actually search and you will see that there's tons of studies that look at PRP within the treatment of knees and hips and ankles and elements of the back and the spine, right? So when you take a look at this, what it shows is a study that basically is a high quality study that looked at a randomized controlled trial that really evaluated this in a multi-center type approach, right? And what they really wanted to do was to evaluate how well PRP really works. So one of the things that they list is, what is PRP, right? And so PRP, as we know, stands for platelet-rich plasma, but the fact of the matter is it's comprised of a lot of different things. So there are platelets that are there are autologous growth factors that are there, there's fibrin that's there, and there's been thoughts about, does the fibrin help unto itself in being able to seal things like fissures and other things along those lines? The question that comes up frequently is, well, if you use an extraneous treatment option, are those growth factors better than autologous? And there are some studies that are looking at that right now. And again, autologous meaning it's coming from your own body, it's your cells, versus you getting it from outside. And there's some thoughts that potentially using your own growth factors may be more effective than extraneous ones. So they give a listing of their inclusion criteria and exclusion criteria, which are pretty common and really relate to many treatments that you would have along surgical options. And then they start giving out what happened after people got injected with PRP. So what they ended up finding is that there was great differences between the control, which is the blue line, and the treatment arm, which shows that after 8 weeks, they were able to see a marked improvement in function, that they were able to see improvements overall in different qualities of pain and qualities of life, that they were able to see changes that took place within the pain score. And this is within an 8 week time frame. And so, how does that compare, relatively speaking, to our conversations about having to wait for that disc to go back in? That's going to take anywhere from potentially 9 to 12 months. And you're talking about getting this done in 2 months. It's a market difference in terms of being able to get sustainable pain relief that didn't require you to have to get a cut, that you didn't have to have an incision that goes through different muscles of the back that require rehab afterwards. So many proponents and oppositional views will say, well, does it always work? Of course not. It's not going to work all the time. And they saw that within the context of the paper that they published and put forth. But we're not trying to talk about therapy that always works, because truth be told, there's very few therapies that always work. There's a failure rate that's present with many. What we need to be able to do is kind of weigh the benefit and both the pros and cons to say, how is this going to be beneficial? How is it not going to be beneficial? Do you have a problem with anesthesia? Do you have a pulmonary issue? Do you have a cardiac issue that really would preclude you from considering surgery? Or do you just not want to be cut and have some potential sequelae from surgery? So that's what we're talking about. So then there's another group that did a completely different study, completely different team that's really well known. That is a group that's present predominantly out of Colorado. That is the Centeno Schultz group that's affiliated with Regenix and Centeno's, or Christopher Centeno's original utilization of Regenix and regenerative medicine, one of the leaders in the field. And what they published was a paper that was looking at treatment of lumbar degenerative disc disease with associated radiculopathy or radicular pain. And what they did was use culture expanded autologous mesenchymal stem cells. So the fact of the matter is, when you use culture expansion, that's a little bit different. And we're going to talk about what does that mean. And for us here in the States currently, that's probably not going to be something that really is going to be reflective, but some of the principles are very similar. So giving you the full details as listed in the paper, culture cell expansion is the following. So what they did was, and I'll read it and then I'll interpret what that means, is they, for the culturing process, they took BMA, which is bone marrow aspirate, where you're taking the cells from that iliac crest that we've talked about in other papers. They did a centrifuge with a spin, and then they took those cells and then they found a way to get that pellet to get to a certain amount after a number of centrifuging techniques, right? And then they took those cells, they washed them, and they resuspended them in culture. And then after 6 to 12 days, they were able to harvest those cells, and they saw an expansion that was able to be replated. And then those cells were then subsequently injected in the future, right? So what does that mean, and why can't we do that? So the FDA doesn't allow for that type of manipulation here in the States. Outside of the States, you can be able to do it a little bit different, but basically it increases the potency. And do we think that that might change in the future? Perhaps, but seeing as what the FDA has put forth recently, it's doubtful that that's going to happen anytime in the near future. But nonetheless, that cell utilization does give benefits. So they list in their paper how they went about giving that re-injection. And that re-injection, if you haven't seen a picture like this is looking at the lumbar spine, and it's an X-ray. The dark black marks are the actual needles. And then the areas that are in and around there, which we'll show with our model that we did earlier, are the areas that we're injecting into the disc, but are avoiding being able to get within the context of the neuroforamen. And they're using, in essence, kind of a Camden's type approach, which we'll cover in another video. So anyway, what that basically means is if we're taking a look and we're trying to basically mimic that model, let me change some things around here so you can kind of see exactly how that looks. If we're looking at this position, one of the things that we want to see is how do we get to the context of this disc? And we don't want to get into the nerve root, and we don't want to get into the spinal cord, right? So what we want to do is we need to be far enough forward to enter the disc and not have the possibility of entering in here. And so they use a certain type of positioning by finding something that's called a superior articulating process to basically make sure that that needle hugs into that disc and is able to enter into the area. And as you start looking at some other papers and what's going on, they can even be able to identify where is the pathology of the disc bulge and eventually be able to place those cells closer to the area that's in question. But at the end of the day, we don't really care about all that. What we care about is, did it work, right? And so these are the results. What they're able to see is a considerable improvement in patients of their degree of pain relief, and saw that there was improvement across the board that pretty much stayed somewhere between 80 and 75%, and it wasn't short-lived. What they saw that it was pretty steady throughout 12 months, 2 years, 4 years, 5 years, and pretty much 6 years. And that's significant because if you're talking about giving someone a treatment, it's different than what we're talking about, like an epidural steroid injection, which may not be sustainable for most people. Can we be able to use treatment options that have limited risk in terms of a graft versus host, where you're getting something extraneous that's coming from outside of yourself, and you're able to get an improvement in pain that could have easily lasted you a year, if not longer, required you to have surgery, which could be debilitating in nature, and we're able to intervene by using a fairly simple procedure to get that type of response. So this, continuing in the paper, looked at differences that took place within the size of the disc bulge and what were the percentage of patients. About 50% of patients had somewhere around a 15 to 20% reduction in that bulge, which was significant enough to really kind of give those results that you saw earlier. And probably just a little bit greater than 25%, maybe close to 30%, had about a third of the change of that bulge. So many times we think that, that bulge has to be completely eradicated and removed like you would when you think about potentially doing surgery. And that's not necessarily the case. When we take a look at pictures that show the bulges and what happened after an intradiscal injection, what we're able to see is the following. So if you take a look at the context of that bulge, you can be able to see. So this picture that you're looking at, let me kind of give you context. So the pictures on the left-hand side are if we're looking at the spine like this, what we're doing is we're taking and turning that person to the side, and we're looking at it in profile. So we can see the back's back here, that this is the disc here, and then up front would be their stomach, okay? And then you're taking a look and you're looking at it like this, so that if you were to be able to kind of take a look and know this would be where your disc would be, your stomach and belly would be up here, your back would be back here, and we're able then to be able to see exactly what's going on with the spinal cord and how that disc is pushing back against where those nerve roots are present. So again, when we take a look, you can see the structures that are highlighted in white are the areas of the spinal cord. And then when you look to the right-hand side, you can see that same representation. And what we're really trying to identify is that black structure that's here, that's pressing against the disc. And then post-treatment, you can see that resolution where that disc bulge is not giving that squeeze, that it's not as sizable as what it had been previously. And so that's what we're talking about when we're talking about using an orthobiologic, or in essence, how do we use a treatment option for the musculoskeletal condition that really revolves around different types of cells that you can place within the intradiscal space to get improvement, and not have to do a mechanical resection, which is extensive in nature, in order to get the response that you're interested in. So hopefully this has been understandable. For those of you who have questions, please pose them. What I would say to many patients is that most of the time you won't hear these type of options mentioned. And these are things that you need to be able to find resources for and figure out how can you be able to learn how to really know all your different options. We hope that the videos that we give to you help explain this. Our channel is clearly not the only channel that explains this. If you're interested in being a subscriber to our YouTube channel, you can see the link below. For those people who you think might have some benefit, please let them know. It's Cutting Edge Pain Relief, which is different from our actual clinical site, which is cuttingedgepain.com. If you're interested in things like how we do cells, and you go to the link that you can see here, you can see the different ways on how we do it, which isn't necessarily always the same way as what you see in those papers. And if you're interested in really kind of learning a little bit more in depth and detail about regenerative medicine and other treatments as a whole, by all means, take a look at our newsletter and becoming a member, because we don't just let you know about these different videos that come out. We also have various different handouts and PDF documentations about different types of exercises, as well as what are things for you to avoid, how we're doing other innovative things like looking at what you can do with your diet, how can you measure different things in your labs to kind of understand whether you might be a better regenerative medicine candidate versus not, how to be able to use technology using different things like physical therapy on the computer to help you with exercises that can be able to increase or decrease with your activity, and really kind of pushing the envelope so that you can be the best that you can be and function the way that you really want to be able to function. So if you found this video helpful and you're watching this at a later date and not part of our live stream, please consider giving us a thumbs up. And if you think that topics like this might be of interest to you, please subscribe to our channel. It helps us be able to reach a broader patient base and base of how we can be able to really provide relief and understanding for patients that really are in a dire strait. And if there are really topics that you're interested in, leave them in the comments. We want to be able to really answer your questions and help you be able to punch pain in the face and get back to leading the life that you deserve. Again, thank you for joining us and have a great day.